at the World Lung meeting, we saw more new data and materials being promoted about serum-based testing of biomarkers. Certainly more than I've seen at a prior meeting. And it seems like the technology is approaching a cusp of true clinical utility. What's your thoughts? How are you using serum-based testing or even urine-based testing? I've seen a little bit of work on. Is that something that you're using at all now? Is it something that you think is fast approaching or still kind of in the distant future and inferior to tissue-based testing? Ben, I'll start with you.
Yeah, so I think a challenge with lung cancer patients is getting serial biopsies. And now we're in a situation where getting a repeat biopsy can actually change treatment. And the example of that is a patient with an EGFR mutation who's progressing on what we now call first-generation EGFR inhibitors. If these patients have another biopsy that of their disease that has progressed that shows a T790M mutation, then they're likely to benefit from a third-generation inhibitor. But for a lot of patients, these biopsies are difficult to get, and I think that's the real place that plasma DNA testing is likely to first make a clinical impact. And things like T790M change over time. Technology like blood-based testing allows us to follow that in a patient in a very non-invasive manner. Mm-hmm. So I think that's probably the first place that...
And these drugs are really coming out, hopefully in the next few months, where there's going to be a much greater demand for repeat biopsies of some type, whether it is tissue biopsies or a so-called liquid biopsy, a blood, serum test. Leora, what are your thoughts here?
So Alicia Sequist had really nice data at ASCO showing that there was good sensitivity with the blood-based testing for T790M. Mm-hmm. So I think that it is going to be something that's going to be more readily used. It's easier for patients, especially in smaller community settings where there may not be an interventional radiologist or an interventional pulmonologist who can readily go get tissue. And patients, if they know their disease is progressing, will want to switch. I think where it'll get a little bit difficult is if we start using them routinely and you see a patient on an EGFR inhibitor has now developed T790M in their blood, but their CT scan looks good. Are we going to be using this for monitoring, and what do you do in that situation?
Yeah, I think that's a different question of using it sequentially to monitor impending progression or, serum-based progression versus clinical progression. I personally feel like that would be a real mistake. We don't have enough good therapies that we should discard any effective therapy too early based on a number that doesn't have any good clinical correlate. To me, it's like looking at a telescope and seeing a meteor coming in, 30 years and freaking out about it now. Yeah. Already you could do things like PET scanning all the time or use something as old and as CEA levels. And sometimes we see people get taken off of chemotherapy or a targeted therapy that they're tolerating well and their scans don't change, but their CEA went from 33 to 40, and that triggered what I would say is an ill-advised change, and I'd be afraid of somebody seeing T790M on a blood test and making a change too early.
I agree. There is no current data that supports changing from a first-generation EGFR inhibitor to a third generation just based on the presence of a T790M mutation in blood in the absence of disease progression on the basis of the current data.
I agree with you, but you're going to see it.
No doubt.
And that's what I worry about.
We already see people getting taken off of treatments based on CEA levels or a PET scan.
It becomes brighter. Yeah.
And this is just, to me, it seems like you're just changing lanes in traffic. It's not getting you anywhere faster. It's just, don't just stand there, do something as if that's a reason to make a change.